Wellness. I'm so glad to see many familiar faces in this group, many of them. So I'm not telling hi to each and every one of you. Thank you so much, Rutula, for one more session with us. Dr. Rutula has done her MD in palliative medicine from Tata Memorial Hospital, Mumbai, and currently she is assistant professor in palliative medicine in Bharati Hospital, Pune. She has been with us for last few training programs. Now she is involved in on some of our on-site training programs also. Rutula has a special interest in research in non-oncology. As FCPM mentioned, it is a very, very broad topic. It is not, when we can't cover the palliative care needs in non-oncology patients in one session. Most of these things we have to learn while we practice or on our journey through palliative care. But I think Rutula will be covering the most important aspects of it by today's session. Welcome, Dr. Rutula, and over to you.
Thank you so much for the very kind introduction, and hello everyone. So we'll be discussing, as Shri mentioned, a very, very broad topic of palliative medicine and non-oncology. Just before we start the session, Shri, is it possible for you to share the screen, because mine is not very compatible with Zoom. Like, for some reason it does not kind of share the.
Sure, ma'am. Just give me one moment, because I had not checked the mail till now. So just give me.
Yeah, sure. Anything else you would like to add to what sir said?
It will contain all the aspects like the physical, social, psychological, and spiritual.
Right. Yeah. Some Shravani says improving suffering due to the illness. Yes, correct. So where do you think, when do you think palliative medicine intervention should start? Like, what would be the appropriate time when it should start?
Whenever
the patient is symptomatic.
When the patient is suffering from pain.
Okay. Anything else? Yes, it is focused on improving the quality of life.
At the time of the diagnosis, according to the WHO.
Correct. Yes. So, many people mention that it should be right at the beginning when a life-limiting illness, whichever it may be, is diagnosed. So, and few of the
when patient complains of pain and suffering, it should start at that time.
Okay. Okay. So can you tell me few diseases or disease trajectories where palliative medicine intervention is possible? Non-oncology, right? Like, so cancer is given, like cancer, it is needed. So apart from cancer, can you...
it can be rheumatic diseases.
Rheumatic diseases, paraplegia,
COPD, asthma.
Neurological disease.
Neurological
HIV/AIDS.
AIDS.
End stage renal, end stage cardiac.
Yes. COPD, yes. IPD, yes. Okay, great. So we know most of the disease trajectories that can potentially benefit from palliative medicine intervention. So next slide, please. So definition, as you all know, is palliative medicine as an approach which improves the quality of life of patients, which can be adults or children, and their families who are facing problems that are associated with life-limiting illnesses. So this, they said, is possible by early identification with correct assessment of the symptoms, which can either be, as you correctly said, physical, psychological, or spiritual. Next slide, please. So I'm sure you've seen this diagram many times. So what they say is that palliative medicine intervention should be given right at, as you correctly said, right when the disease is diagnosed. And it increases over the period of time when, along with your disease modifying therapy that is going on. And it even more so when the disease modifying treatment is no longer working as well. So that time the role of palliative care would increase, in fact, and it also kind of extends to beyond the death of the patient into bereavement care. Now, what it is important to note is that here, though it is shown that it is a linear increase in the need for palliative care or palliative medicine, it is not linear. It can wax and wane. It sometimes the needs might be more when the symptoms of the patient suffering from these diseases is more, and we might take a back step when there is no need for a palliative medicine intervention. So it is up and down. It is not linear. So that is important to note. Next slide, please. Again, to show that it goes hand in hand with the disease management or disease modifying treatment along with your rehabilitation. And also you need to take into account that because you know that the trajectory is such that eventually it will lead to deterioration of the patient leading to the death of the patient. So we need to have some kind of advanced care planning or advanced directives if that is possible in patients, and then proceed either if the treatment works out well and the patient is cured, let's say, of cancer, then into survivorship or into bereavement care as what happens with the patient. Next slide, please. So before we start with the non-oncology palliative medicine, there are certain competencies which are recognized worldwide now that a palliative medicine physician or health professional should have. So first, they should know what a palliative care approach to care to the care of the patient is. So they should be able to identify when the patient is in need for palliative care and should be able to refer them to a specialist palliative care physician if required. Then they should be able to address the symptoms, pain specifically, because pain is one of the most commonest symptoms, not only in oncology, but in non-oncology as well. So they should be able to address all the basic symptoms, that is pain, your fatigue, anxiety, depression, breathlessness, anorexia, cachexia, etc. And they should be able to take proper history and treat the cause if it is correctable, or give them proper medicine if it is irreversible. Next slide, please. Then they should be able to participate in proper care of a dying patient and their families. We should be able to identify what the signs of dying are, or that the patient is approaching death. And while doing so, we should be able to prepare and educate the patient and the relatives that the patient like eventually is dying or is very near to dying, and how to take care of the body when the patient does die. Next slide, please. Then address psychosocial and spiritual needs. So there are various tools to assess psychosocial needs and spiritual needs, to use those properly and to assess if there are any breach in the care that we are giving, and if there is any need for spiritual interventions or psychosocial interventions, and how to manage it very delicately, because all these are very touchy topics. So not many people are open to discussing their psychosocial needs or spiritual needs. So we need to be very careful while assessing those and addressing those. Then to address the end of life decision, help them making the plan, and execute the plan as well. And this should be kept in mind that this should be along with the bioethical guidelines or legal frameworks that are present in your institute or in your state, or where you're working, in the region that you're working in, because they differ from place to places in India. Next slide, please. Then we should be able to have good communication skills, not only with the patient, but their families and caregivers and extended families, as is very common in our country. And also to remember that every symptom is multimodal and the suffering is multimodal. So one interlinks with the other, reaching down to the first one. So if you want to treat the suffering of the patient, you should address all the possible dimensions that can lead to that suffering. So always remember it's multi-dimensional, and to address all of them together for effective management. Next slide, please. This is the last one, but it's a very important competency to have, is that to have self-awareness and to be self-caring. Remember that if you're not your 100%, you cannot give your 100% to your patients. So take care of yourself. Admit that you're tired when you're tired. Engage, because it's a branch where you deal with a lot of deaths, and you deal with a lot of suffering, not only physical but even psychological. And when the patient or the relatives share that with you, you kind of relate to them a lot, and there is a chance that you feel for them, because you're with the patient a lot longer time than the others, because you'll be constantly monitoring them and taking care of them constantly. So you might feel some self burnout, or you might feel that sometimes it's very subtle things, like you get angry really fast, or you kind of uh, take everything very casually, something which you would not have taken so casually maybe a couple of months back. So it's a very subtle things that changes, but it is important to be aware that those can potentially happen, and to take care of yourself, maybe take a break for a day or two, or just engage in whatever hobbies that you enjoy on a regular basis, so that you have that mind diverted from the regular gloom and doom of what is there in palliative medicine. Next slide, please. Now, coming down to what we actually are looking at, I'm sure you've seen these graphs before. So what graph A symbolizes is a sudden death, which we all hope for, which is like a sudden thing, you don't realize what is happening and you just gone, like that is what you're hoping for. Or in the sleep, where you're not aware of what is happening, and you just peacefully in the sense, like almost most of the time peacefully, you die. Then B is a terminal illness, where you are okay for a couple of years, months or years when the treatment is going on, but then you start deteriorating because it's no longer responding to the treatment, and with the deterioration you die. So this mostly can be seen in oncology patients. Then comes in your organ failure, which, as you can see, it's up and down with the health never coming back to the baseline that you can see on the x-axis. So it always goes down after the dip in the health, and that those dips indicate a potential hospitalization, where there is an exacerbation of whatever underlying disease is. So it goes down continuously, and the last hospitalization leads to death, because the treatments are no longer working on it. And D is old age, or frailty as you call it, where there is a decrease in the function in itself because of the normal aging process that occurs, and will lead to death because of the the aging process and decrease in the function slowly over time, and leading to all function shutdown. Next slide, please. So what we are going to deal with is mostly graph C that we saw, that is, organ function dysfunctions and organ failures. So likely to benefit in all, like as you guys said, organ failures, you have your neurodegenerative diseases like dementias and Parkinson's, etc. You have your rheumatological diseases, you have your cancer patients, you have HIV and AIDS, you have your even diabetes is long-term illness, which leads to a lot of organ dysfunctions in the end. So that can come under palliative care. Then you have your prolonged ICU stays, which are not benefiting a lot from whatever interventions you're giving. And sometimes those who have multi-system failure but are on let's say ventilator and dialysis and everything, just for supporting the continuation of life. So such patients are also part of the spectrum that comes under palliative medicine. Next slide, please. So what do you think are the barriers? So the barriers can be either physician barriers, like, the physicians themselves are reluctant to, kind of refer patients to palliative care, or they can be, carers or patient barriers themselves. Next slide, please. Okay, so next, just one more click. Yeah. So in non-oncology, it is specifically very difficult because, as we saw, the trajectory is such that you always feel that the patient will come out of it, right? Because, after every hospitalization, though the health was never as good as it was before the diagnosis of the disease, but, he or she always came out of the hospital and was near normal to what it was before. So because of the trajectory, the patients, the relatives, and even the doctors feel that, no, we can always do something for the patient. So the trajectory itself is such that it is very difficult to, kind of prognosticate when it will be the last exacerbation and when it will be the last time that the patient is coming to the hospital. So what do you think are the barriers, or physician's perspective is not to refer to palliative medicine? Anyone? Just unmute and just say. Just one.
As you told, they always think it is irreversible.
Yes. Right.
So that is the main thing.
Yes.
I see.
Anything
One is to keep trying to extend the life irrespective of the quality.
Yes, not giving up, basically.
Yeah.
Pressure from the relatives.
Okay. Anything else?
Be a lack of awareness.
Lack of awareness. Yes, very good.
Even lack of availability of palliative physicians.
Yes.
Presence of
medical legal
palliative care is misconception that palliative care is only for terminal illness.
Right. Only for cancer specifically.
Cancer.
Yes.
Misconception.
Medical legal implications that if they don't give acute care, they could be taken to task.
Yes, that's a good one. Yeah. Okay. Can you just go next till the end of the slide? Another, yeah. Just one behind. Thank you. So as you guys have correctly said and added to what is on the list, so the physicians always want to be like, I'm going to cure the patient. So, they do not want to give up. As you've correctly said, they always want to cure and always think that, no, the patient will come out of this, even this time, the event this time as well. They take it as giving up on the patient. So, and because of this, they take it as a personal failure to what has happening or what will happen to the patient. So they have this not a guilt per se, but kind of, maybe it's an ego thing, I'm not sure. They just take it like, oh my, I couldn't save the patient, I couldn't do anything for my patient. So they kind of internalize all the angst that comes with losing a patient and turn it into a self guilt or self blame that they couldn't do 100% for their patient. And as you correctly said, there is a general lack of knowledge of what palliative medicine entails, and the perception that it is mostly to deal with cancer patients and nothing else. Next slide, please. So yeah, so what are the caregivers' perspectives? What do you think will be the barriers why the caregivers do not want to be referred to palliative medicine?
Again, lack of knowledge and awareness, and the thought that it is for the end of life.
Yes. Very good.
Could it be a feeling that they may lose the patient or something of that sort?
Maybe it can happen. Yes.
It's also difficult for a caregiver to take the decision because they think of it as end of life.
Yes.
So who can decide to pull the plug and those kinds of things. Social pressure.
Yes.
The functionality of the patient might reduce with all the medications we give.
Right.
Different members of the same family will have different opinions.
Right. Financial concerns. Okay. Ability to give, ability to give time to the, okay.
Yeah, even in my practice, I have seen that even the society, they feel that sending a patient in their to a palliative care, even the society will blame that they have opted this because they don't want to spend much money.
Right, right. The very filmy dialogue, log kya kahenge? It's always like, what will people say, like if I do this and if I don't do that. Correct. Can we go till the end of this slide, please? There's one more, yeah. So as you know, as I mentioned before, the disease trajectory is such that everyone thinks that they'll kind of come out of the ICU or come out of the hospital after they've been admitted. And obviously, even if we were in the place of the decision maker or the patient, we would want everything to be done for ourselves as well, or for our loved ones, because we don't want to lose them. At the end of the day, it's always that you don't want to lose your loved one, so that is always there. A sense of guilt is there, especially in a generation nowadays where the children are abroad somewhere, the parents are here, the parents are admitted, and they come to know that it's serious enough not to pull through to being discharged even from the ICU. They always feel that man, I wasn't there for them, and it cannot be that I haven't done anything for them. So they kind of want to prolong being in the hospital or the ICU despite whatever happens, because that they feel that they haven't done enough for their parents or for their loved ones. And as I said, what will people say? That is always, especially in our society, where we care more about what people say than what we would want to be done for ourselves or for our children or for our parents. Next slide, please. So coming down to so we'll go system wise. We will take up most common symptoms from all the, I'm not going into the details of all the diseases and the disease, what the disease pertains. We'll be looking at the most common symptoms that will be present in the system. So I'm talking about central nervous system, cardiac system, respiratory, hepatobiliary, and your nephro. So we'll go into the commonest symptoms and how to manage or deal with them. And but there are a vast number of things that are apart from these as well. So there are stuff like diabetic foot will be there, you'll have your bed sores, you'll have other symptoms which you'll have to deal even in non-oncology patients, but I've not mentioned them here. So but they'll be covered like everywhere, or it's more or less the same management as you would do it in your day-to-day practice as well. But I'm specifying on the symptoms as we go along. So coming to the CNS diseases, so mostly they are your dementias, you have your Parkinson's disease, you'll have your post-stroke patients, and traumatic brain injuries. Next slide, please. So the commonest symptoms you would see would be your plasias or paresis, can be hemi, para, quadri, whichever. You'll have your seizures, you'll have dystonias, dysphasias and aphasias sometimes. Next slide, please. So management wise, rehabilitation comes in all the systems and everywhere. Like you would want to give some sort of rehabilitative measures to all your patients just to improve their functionality. It might be simple, might be a TB patients with pleural effusion. That it is nothing else apart from the TB induced pleural effusion, but give some sort of chest physiotherapy to the patient. It just helps them overall. It'll help them reduce the symptoms of breathlessness, and just also help with this lung expansion, though the study much over the period, but it just kind of gives them the ability to cope up with the symptoms better. So rehabilitative measures goes hand in hand in all the systems across the board. Baclofen and muscle relaxants. So what is your idea about muscle relaxants in general? When so here it can be used in hypertonias and even in dysphagia sometimes, if it's odynophagia wise and it is because of the muscle spasticity, sometimes a muscle relaxant might just help with decrease the pain while swallowing. So muscle relaxant form a cornerstone in managing pain due to contractures, or your hemiplegia or paraplegia patients, they kind of have that muscle stiffness that goes along with it. So muscle relaxants go a long way in helping in these patients. Analgesics as well. So wherever you feel that your basic analgesics like paracetamol or NSAIDs are not working, please be liberal enough to use opioids. And I'm not talking about just tramadol and tapentadol. Please feel free to use strong opioids as well, because given in a safe environment and in a monitored environment, they go a long way in helping patients. And trust me on this, like I have seen a couple, so she wasn't even a terminal illness. There is this patient with disc prolapse. So she had excruciating pain because of the prolapse, and she was kind of reluctant to undergo surgery for it. And which though she did undergo surgery a couple of months back now, but even after that she was hardly able to walk. So I just had a video consultation with her yesterday, and she just mentioned that you have given me a different life. I can walk 1,500 steps now, where I could only walk 300 steps before. So, and I've given her morphine, like oral morphine, and that is helping her so much that she can at least walk around the house and do her daily activities, where, when I'd seen her the first time, she could hardly stand for 2 minutes. She couldn't even stand for 2 minutes. That was the level of pain that she was suffering through. So please feel be liberal enough in prescribing opioids where you feel it is necessary. And I agree with you in that it needs to be monitored and it needs to be tapered down when you feel that there is no more use of the said opioid. But please feel free to give opioids in patients where required. Anti-epileptics, usually still most of the patients, most of the places prefer phenytoin or valproate, but the safest one nowadays is Livera. But it again depends on what you are comfortable with and how you want to titrate it. But go titrate it up if required, titrate it down if required. Then your NG tube versus peg feeding. Now, so what is your opinion about NG tube feeding or peg feeding in patients with, let's say, quadriplegia or dementias as well? What is your overall thinking about should NG tube be placed or peg tube be placed?
Peg tube.
Okay, should it be placed? Should it not be placed? Let's start from that.
It depends on how much is the nutrition affected, because I mean, it definitely has a psychological negative influence on the patient and the relatives, and it can be irritating also a lot of times. And so many patients pull it out, and then again it's a trouble for the relatives to arrange it. But when the nutrition is affected severely, then that should be the major concern, and that should be given.
Okay. So okay, suppose let's say the nutrition is affected. Let's make it into two scenarios. First scenario is nutrition is affected, but so and the patient is willing for either NG or peg feed. Which would you prefer, NG tube or peg tube?
If they can afford peg tube, otherwise NG.
What is the additional PEG, yes. Okay. So what is the additional benefit of PEG over?
You avoid
NG?
aspiration pneumonia. Aspiration.
Yes. And
With PEG, it
very
is a
convenient to
long-term
manage.
nutrition.
Comfortable for the patient, and patient socially, patient can interact with others without that tube.
exactly. So, it's kind of socially, aesthetically very neutral. Like no one will know that there is a tube, somewhere.
And the maintenance is also
Maintenance, yeah, I think both are similar. Like, the width is almost the same, I think, in both PEG tube and NG tube. And I think I'm not sure about the cleaning process of PEG tube, because I've not, like, as you said, not many people can afford PEG tubes in our country. But I'm not sure how they, like,
even
assuming
I'm not
it's the same.
very sure, but I think it has little wider
Okay.
diameter.
I'll have to find that out. I'll actually find that out, and yeah, okay.
It is
Good point.
invasive procedure, pig feeding.
Yes, it's an invasive process. And it's
Invasive.
expensive.
It's
Yes.
non-invasive.
Yes, yes. Okay, and so in scenario 2, let's say, though the nutrition is affected, but the patient is nearing end of life. Like, you expect that the patient does not have, let's say, more than maximum a week. Would you still want to put in a NG tube or PEG tube, let's say? They are affording.
Preferably discuss with the patient all the benefits and negatives.
Okay. But you will still want to put it in, like, even if
the patient is very accommodating and willing for that, maybe.
If the lifetime is too short, then there is no advantage.
it's
If it is,
maximum a week. It's maximum.
then in that
Then
case,
there
In case of
no
weak,
advantage.
in case of weak, you can avoid the intervention procedures.
yeah.
Exactly. So, sorry, we couldn't hear you, ma'am.
That was an unintentional unmuting, I believe, doctor. You can
Okay, okay. Yeah. So, as we were discussing, it's basically depends on the situation of the patient. Even so, sometimes even if the patient is nutritionally deficit, we might not want to put it if the patient is nearing end of life. And we might need to look into the potential benefits versus the cons of putting in the NG tube or PEG tube. Like, suppose a patient is very aggressive, and that there's a high chance that he'll pull out all the things and cause more harm than necessary to himself or herself, then you might want to put it in, but in a safer environment where you will be able to kind of handle the irritability and aggressiveness that comes in with whatever he is going through. So you need to have that environment as well, and then you'll have to educate the caretakers and the patient himself or herself to manage the PEG tube or the NG tube, how to feed themselves, what kind of feeds to give and what not to give, because it depends. Like, if it is so here we are just talking about gastric tube or gastrostomy. If it is a jejunostomy or an NJ tube, the feeds need to be semi digested. So they again change. So what to give, what not to give, you'll maybe need to get a dietitian involved just to have a very clear idea about what can be given, cannot be given. Then coming to speech aids, it's a kind of a rehabilitative measures again in itself, but it's important for communication, like for the communication of relatives with the patient or with us as well. There are various techniques which can be used. Like, so if the patient is aphasic but is able to blink and is coherent enough, then asking direct questions and asking him to blink twice for a yes answer and once for a no answer, that is one way of kind of communicating with him or her. Others are, you have your laser guided speech aids, or vision guided speech aids, but you'll have to find out which is available where to put it into use. And sometimes it might not be very accessible in most of the regions in our country. And even if they are available there, they can be very costly. So we need to put everything in, we will have to keep everything in mind before we describe these. There were few questions in the chat box which say what kind of muscle relaxants to be used for dysphagia and stroke contractures. So usually here centrally acting would work better. Clofin would be a better choice, but again you'll have to kind of titrate the dose according to what the patient requires. It should not be that it becomes too much of a dose or too less a dose. So you'll have to monitor it quite well for a couple of days at least. And for contractures, you would want to give physiotherapy as well along with the muscle relaxant, so that it goes hand in hand. For this patient, so she was not opioid naive. The patient I was talking about, the disc prolapse patient, she was not opioid naive. She had already received I think a week or 15 days of morphine before she saw me. So I switched her back on to what dose they had given. So they had given her 10 milligrams 4 times a day. So I restarted her on the same dose. And now I've up titrated to 60 mg per day. So we did go up with an intermittent. Sometimes she needs 1 tablet extra as well. So approximately 60 to 70 milligrams per day. She's currently now on that much of it. Hoping to reduce it down since she's post-operative and all. But she's still in a lot of pain. So her physiotherapy is going on, and once she stabilizes enough, I'm hoping I'll get it down to a bare minimum and stop it eventually.
Ma'am, how old is the patient?
She's around 55 or 56. Acceptance by family members may be difficult. Yes, it is always difficult. And we need to address the concerns of the patient and the caregivers and try to make them understand that it might not benefit. Yes. So, communication becomes a very tricky thing, especially in traumatic brain injuries or young patients, young stroke as well, so it's kind of disheartening even for us to see a young patient suffer so much. So especially in them, it becomes a bit tricky on how to manage them. But yes, I completely agree with you that we need to address the concerns of the patient and the caregivers. Subcutaneous infusions in patients, yes, but not a lot of not even a lot of doctors are comfortable with using subcutaneous infusions, like even for IV fluids, like especially where I work in. When I say that, why not give like a subcutaneous slow infusion of NS or DNS, they're like, why subcutaneous? We'll just prefer IV, so at least in where I work in, they're not very comfortable with it. But if you guys are using it regularly and it's a
When we
common
give
practice,
subcutaneous when we can't find the veins.
like infusions, you keep them on infusions and as continuous infusions and everything. Because we have found it to be like, even the nurses are all surprised, like, are you sure you want to put in like a subcutaneous infusion catheter and stuff? So we use like the smallest intravenous catheter possible and put it subcute and started an infusion on a couple of patients. But the sisters all were so very uncomfortable doing that. They prefer so I agree with you, subcutaneous infusions are actually relatively better, and the access, it does not depend upon IV access and everything. So they are actually better, but not many are comfortable in doing them.
Actually, we do a lot in pallium. We do a lot of subcutaneous infusions in pallium. Even infusions, opioid infusions, we give through the subcutaneous route using our syringe driver.
Okay, so here they are not comfortable. Okay, I'm assuming it's all because of I like the Pallium India has made it very wide known and very accessible, but not everywhere else. Like even Once I remember when I was in working in Tata, that time also we had just put in, because we've read so much about subcutaneous infusions and everything. There also we tried, but the sisters were like, we'll find the vein and we'll give it via vein. Why do you give it subcutaneous? So they have a kind of a reluctance. I'm not sure why. Maximum rate of infusion, it's actually very slow. So around, I think 30 cc per hour would be the maximum via subcute, but I'm not sure. Can you elaborate on that? I'm not very I've not used it much. So
I just typed it in the chat. At one site, you can give up to 1.5 liters.
Okay.
Yeah, but very slow infusion. Very slow infusion.
Okay.
You have to make sure that to tell them that there can be slight swelling at the site because of the accumulation of fluid in the site. It is unlike in IV cannulation. You don't need to worry about the swelling, and it will just disappear after some time. So that's education is there. We do give it in the home care setting, and we educate the caregivers to control the speed if there is a swelling and stop it and remove it. Share some articles in the group, because I'm not focusing that on subcutaneous, because I am understanding Rutula has a lot of topics to cover. We can send you an article on subcutaneous infusions. So you can refer to it.
Great. Okay. Next slide, please. Thank you, Shri. So coming to CVS, there is your heart failure. You have your congenital heart diseases, which sometimes might lead to isomengerization. Next slide, please. So the symptoms that we commonly see would be your breathlessness, chest pain or chest heaviness. You have your palpitations, which they perceive as increase in heart rate and feeling of anxiety. You'll have your peripheral edema. You have cough, which sometimes might even lead to hemoptysis. Fatigue is there. You have your sleep disturbances. Next slide, please. So as I said, rehabilitative measures wherever required. Do you think opioids should be given here? Anyone?
Can be given if there is a respiratory distress due to cardiac failure.
Okay, but otherwise?
Breathlessness.
Yes, anything else? So if you remember when we used to read like cardiac ischemia or a severe, like a patient who comes with like a severe sharp shooting pain in the chest, the first thing they would say is like with nitroglycerin you should give morphine for that pain. So technically speaking, it's been like an ancient way of managing chest pain. So opioids again should be liberally given wherever required, not only for breathlessness and respiratory distress, but also for the pain. Diuretics are important because they decrease the preload and eventually help manage the symptoms better. So it will help with your breathlessness as well, with your edema. It will even help in reducing the palpitations and chest heaviness in some patients. Beta blockers is again as and when required by the patient. So they should be given in situations where it is required and not to all, just to reduce the heart rates and just kind of decrease that feeling of anxiety. Oxygen support, again, it's important to remember that oxygen is also a medicine. So use it stringently. Do not just give it, hare breathless hai, oxygen laga diya. So do not do that. If required, give oxygen. So in an elderly patient with chronic heart failure, you will expect the saturation to be low. If the patient is not air hungry, so sometimes they might not even feel breathless. You will visibly see them to be like, tachypneic and, breathless, but they will not complain that they are breathless because they are used to that low saturation. Like their limit has been set down to the low saturation. You might not require to give oxygen support. right? In patients who are air hungry and who are visibly like, I can't breathe, I cannot, this like something is choking me. Sometimes they'll various descriptions of what they are feeling. That time, oxygen support becomes a necessary part of it. So use oxygen stringently and in a monitored way as well. Next slide, please.
Madam, what about digoxin?
Yes, wherever required. So I did not go into the details of managing the cardiac illness per se, but whatever is going on, whatever is helping the patient, of course, that goes on. So I'm just talking about the symptom management here. But underlying disease modifying treatment or disease treatment goes on along with our medications as well. Then coming to respiratory system, we have end stage COPD, end stage ILD, you have your core pulmonary and pulmonary embolism sometimes. Next slide, please. So cardiac symptoms and respiratory symptoms overlap a lot. We have your breathlessness, you have weight loss, fatigue, delirium, palpitations, you have headache because hypoxia induced or an headache nevertheless. Next slide, please. So again, the managements are more or less the same. Opioids here mainly for the respiratory depression, distress and breathlessness. Diuretics again, especially if there is a lot of pulmonary edema or there are few evidences which state that furosemide nebulization helps with breathlessness. So they might decrease the edema in the airways, thus leading to the feeling of decreased breathlessness. But some patients, not all the patients, we've tried it in a couple of patients, but not all the patients respond equally. So sometimes it might help. N-acetylcysteine helps in quite a lot of patients, especially if there is a lot of thick mucoid secretions which is not coming out properly despite good chest physiotherapy. You might just give an acetylcysteine nebulization to thin out the secretions and then give the chest physiotherapy. It helps them kind of expectorate all those things out. Oxygen support, again, where required, it should be given. Antipsychotics here I've written because it's common for these patients to develop delirium, either hypoxia induced or NCAF induced. But so antipsychotics might become a regular part of their prescription, and steroids as and when required in ILD patients, in exacerbation of COPD, along with your antibiotics, just to reduce the inflammation in the parenchyma. Next slide, please. Coming to the hepatobiliary, we have your end-stage liver diseases, which can be liver cirrhosis or liver failure. Next slide, please. So you have the symptoms of mostly nausea, vomiting, fatigue, weight loss, and then all the signs of liver failure that you can see, including hepatic encephalopathy. Next slide, please. So rehabilitative measures, as I said before. Here, what would be your antiemetic of choice? Anyone? And why? Why would you choose that antiemetic? Ondansetron, yes, excellent. Why would you give ondansetron?
It's centrally acting.
Yes, and what is the reason for your nausea here?
Ammonia-induced toxicity.
Hepatic failure, let's say.
Ammonia-induced toxicity.
Increase ammonia.
Yes. So basically, you need something that will cross the blood-brain barrier, right? So your any medicine that is centrally acting. So even metoclopramide will work, ondansetron will work, your haloperidol will work. So anything that is centrally acting, right? Excellent. So there is a lot of, I've written sertraline. So basically that is for pruritus. It is very common in hepatic failure and even in uremic patients. Sometimes, they have a lot of pruritus all over and it's severe enough to disturb their sleep, appetite, and their mentation as well. So for patients with hepatic pruritus, sertraline works wonders. And trust me on this, I've given this to a couple of patients and in one day, it responds in one day. So it is an excellent drug for hepatic related pruritus. So, and you can start off with a low dose of, let's say 12 milligrams and up titrate it if required. But usually once a day dosing, I have started 12 mg once a day, and I've up titrated it to around 25. Laxative, why would you want to give a laxative, and which laxative would you prefer?
Lactulose.
Lactulose, excellent. Why?
Again, it's related to the ammonia buildup.
Yes, correct. So basically, it clears out the ammonia from the gut, decreases its excellent.
Ma'am, sertraline, how many days would you give?
You'll have to continue it. If you're not doing anything to correct the, the bilirubin levels, you might have to continue it for a long time. If you're giving some measures or doing some interventions which will reduce the bilirubin levels, then you might taper it down once the bilirubin levels have come down. Excellent. Any other supportive measures that you can think of in hepatobiliary?
Rifaximin.
Rifaximin, excellent. You have your rifaximin, you have your Lola, you have your Udiliv 120 or 300 as whatever you prefer.
I give 550 and 550 BAD.
Yes. And then you might even have to do ascitic tapping sometimes if required, if it's large enough to
Mostly in cirrhotic liver
yes,
disease.
yeah. So, if that is causing a lot of distress, it sometimes even leads to a lot of breathlessness and lower limb edema. So you might just need to give laxative, ascitic tapping. You might have to do some amount of ascitic tapping in these patients.
If there is edema, we can give spironolactone also to.
Yes, yes. So, this will help with your cirrhotic patients. Your diuretics will help with your ascites, but if it's an oncology patient, it might not, because it's kind of mixed, right? Exudative plus transudative. So malignancy patients do not respond very well to spironolactone or furosemide or combination of both. It does help
Portal
them
hypertension.
yeah, it kind of helps them prolong the time between tapping, like from, let's say, 1 week to 2 weeks. It might extend the time, but it might not help them overtly. But in cirrhotic patients, it does help quite a lot. Yes. Next slide, please. Coming to renal diseases, so you have your end-stage renal diseases, which can be due to hypertension, diabetes, or glomerulonephritis. Next slide, please. Yes, albumin infusions would help in these patients, in hepatic patients. So again, some of the symptoms overlap with your hepatobiliary. So you have your nausea, vomiting, you have decreased appetite, fatigue, decreased urine output, and because of that, you have your signs of fluid overload. You have pruritus again, muscle twitches or cramps, and sleep disturbances. Next slide, please. Again, what would be the
Ma'am, for the pruritus in renal case also sertraline?
No, it's different. So the first choice is either your UVB light therapy, and locally applied capsaicin helps in these patients. Then you have your gabapentinoids, which help. And third line is sertraline. If nothing is working, then sertraline. So first is UVA, UVB, mostly UVB light therapy and capsaicin, local capsaicin application. Second line is gabapentinoids. So go for gabapentinoids because we wouldn't like light therapy. We generally do not advise. Antiemetics, again, centrally acting because of urea, excellent. So any centrally acting should help. Best one would be either ondansetron or haloperidol because it has like a larger coverage. Again, laxative here would again mostly be lactulose, and supportive measures when and where required. Gabapentin for antipruritus. Yes. Next slide, please. I'm not sure if they've mentioned this before, but I would just like to point this out because breathlessness is a common symptom in most of the system disorders. Like it might even be precipitated in hepatorenal failure as well. So it's important to know that breathlessness, now they've divided into breathing pattern, your thinking pattern, and your functioning pattern. And all of these are apparently interlinked with each other. Your inefficient breathing, which leads to increase in work of the breath taking, because it might be because of your muscular fatigue or more use of accessory muscles, but which leads to more breathlessness. Then you have your thinking related effects, like you have your anxiety, you have certain misconception which make you feel that, oh, you're going to die and whatnot, or previous experience which kind of paints your current situation. So mainly these lead to anxiety and kind of panic attacks, as you call them, which again leads to increased breathlessness. And functioning, because your functionality is gone down, and because you have reduced activity and everything, leading to deconditioning. So again leads to breathlessness. So in managing breathlessness, you need to focus on all three aspects, that is breathing, thinking, and functioning. So you have your rehabilitative measures, you have your pharmacological methods, and sometimes you might even require CBT or psychological therapies to just manage the breathlessness better than just with pharmacology. So I just wanted to focus on this. I'm sure they'll share the PPT with you, so you can just have a look at this. Next slide, please. I think I'm at the end of it. So next slide, please. So this is what was given by the ISCCM, that is the Indian Society of Critical Care Medicine. So they kind of sat down together with the IAPC to formulate an end-of-life care policy for India. And this is what they came down with. Next slide, please. To put it simply, when there is a prognostic uncertainty according to a physician, and you have consulted other colleagues who also come to the consensus that yes, this is or this is medically futile, or there is no benefit of further treatment, with discussions with the family and the relatives and the patient, if possible, and you've established the goals of care, there it is possible to withhold or withdraw life-sustaining treatment. This is mostly related to the ICU, not patients in the ward or OPD basis, but they can go for withholding or withdrawing of life support and give effective comfort care to patients and appropriate symptom management. So, and document all the things that you're doing, right? Document that there is a prognostic uncertainty and that it is medically futile. Document that you've discussed it with colleagues who are not directly concerned in the patient care. Then document that you've spoken with the relatives and the family and the patient himself, and he has discussed that his wishes, preferences, and values are such and such, and he would like to do this for himself or for the relative. Then you've decided to withhold or withdraw care or whatever that you've documented. and the further plan is comfort care and symptom management, and you're planning this. So document everything clearly. Also mention it to the family members that this is not set in stone. She or he can always come back and change the decisions that they've taken today, and that they can go up back and forth as and when required, and give them full right and liberty to do what they wish to do with the loved ones that they are caring for. Next slide, please. I think I'm at the end of the, yes. So it's a long way ahead, especially in non-oncology patients. And we need to work really hard for that. I'm hoping that becomes a common thing for everywhere in the country. So yes, thank you. Thank you so much. Any questions?
Thank you.
But in
I think there is
palliation, how
one,
long?
yeah.
Yeah. So
About
how long do we
albumin.
give albumin infusion for patients with chronic disease? So it's important to note that the albumin that you give externally has its effect only for 24 hours, that it does not, like, post that it has absolutely no benefit. So, and you usually give just 3 doses of albumin infusion per cycle. So it might not have an added benefit, or if you're asking about the long-term effect of albumin infusion, it will help them reduce the symptoms very quickly, so that if they have like peripheral edema because of hypoalbuminemia, that will get reversed pretty quickly. So you can, do rehabilitative measures for that. But the long-term effect is not so much. So you will have to give them dietary advices along with albumin infusion together. So it will not have a lot of effect. Just the infusion will not have a lot of effect. It just lasts for 24 hours. Yes, it does come back, but then dietary modification would be a better way to go around it than just giving them continuous infusion. Is the video recording while counseling for documentation in the end of life care preferred or allowed? What's your opinion? So certain hospitals have a video recording going on in their counseling rooms just for their medical legal purposes. I'm not sure if you're allowed to audio record them. I'm really not sure. You can take permission and say that this will be kept for educational purposes or documentation purposes, and most of the relatives allow you to record it, like they record it without asking for our permission anyways. So but it's better to always ask them for their permission before recording that, because it's a very private conversation, so better to ask for their consent before. So challenge dose reduction in CLD or deranged LFT. So I generally start off with the lowest possible dose. So it's usually just 12 milligrams. That's fairly acceptable in CLD and deranged LFTs. Yeah. Actually, it's more to do with renal deranged RFTs than LFTs, sertraline dosing. So it shouldn't have a problem. Any other questions?
Thank you, Rutula, for presentation. As I said in the beginning, it's kind of learning on the practice. We can't cover all the non-cancer issues that we see in palliative care, and very often the kind of management depends on the illness trajectory and how far the acceptance is there among the caregivers and how far you can provide from your side as a care provider. So it depends on many factors, and it is most often very subjective. But she has covered almost all the aspects really well. Thank you so much, Rutula.
Thank you.
Will move on to the case presentation.
Yes, please. Thank you.
Am I audible?
Yes, ma'am.
Yeah. Good evening, everybody. I'm Dr. Dimple Saigal. I'm doing my private practice in Mumbai. Please excuse the constant noise because there is a municipal road work going outside. So please bear with that. My patient is an 85-year-old female patient. She has severe pain and she's a known case of lumbar canal stenosis. There is a disturbed sleep, anxiety, depression, and urinary incontinence. Next slide. Thank you. So, presenting complaints of a severe pain over the low back and both lower limbs since 15 to 20 years. There's a burning sensation all over the back since approximately 10 years. And now it has involved both the lower limbs and the genital area since 2 to 3 years. Urinary incontinence since 2 to 3 years. And disturbed sleep because of the pain since now many years. The history of illness was she was diagnosed with lumbar canal stenosis 15 to 20 years ago. She was told surgery, but she never wanted that. Uh, there has been a progressive increase in pain since the past 2 to 3 years. And pain is more in the supine position as well as when she gets up from that supine position and starts walking. So if she takes an afternoon nap and tries to get up, that's the time when the pain is maximum. And early morning when she tries to wake up, again the pain is maximum. After she comes and sits in her chair, it gets mildly relieved after about 10 to 15 minutes. She used to be a very avid walker, regular evening walks, but now there has been a progressive deterioration in mobility since the past 4 years. She has not stepped out of her home at all. She lives on the first floor, but there's no lift in the building, so she cannot go down. There are about 20 stairs. She walks with the help of a walker only within her home, and that also is only from her bedroom up to her puja room. Uh, she has a complaint that the pain radiates to both the lower limbs now, and there have been certain instances where while she's en route, say she's coming from her puja room back to her room, she's suddenly unable to lift the right leg while walking, and then she has to call out for help, and someone holds her because there is a feeling that she might fall. There is a burning sensation over the entire back since approximately 10 years, and it was she tried to seek treatment for it, but she was just being told, oh, this is postmenopausal burning sensation, so there's nothing, you have to live with it. And now this burning sensation is involving both the lower limbs and also the genital areas since 2 to 3 years. Sometimes in the middle of her meal she has to get up, go to the washroom, do a little irrigation with water, and then she feels a little relief. She comes back and sits for her lunch. It's that bad. There's urinary incontinence since 2 to 3 years, and it's again most noticeable when she gets up from her supine position and starts walking. That is again after her afternoon nap or early morning. When she tries to walk towards the washroom, there is a lot of incontinence. This has led to a lot of anxiety building up now every time she gets up from supine position. At times, she refuses to rest in the afternoons for the fear that the minute she gets up and tries to walk, she's going to soil her clothes and there's going to be incontinence. Next slide, please. Her medical history is hypothyroidism, asthma, hyperlipidemia. She has a left adhesive capsulitis since 4 to 5 years. No treatment again taken because she's not stepping out of the house at all. And there has been a progressive reduction in the range of movements. There is a history of CA uterus stage 1 many years back. Much of the hospital records as such were not available. So then after the surgery, there was a bowel obstruction history. Approximately 8 years ago, hospitalized and treated with medical management. There's diminished hearing in both ears, right eye cataract, uh, obesity. She was hospitalized and treated with remdesivir for COVID-19 in 21. Surgical history was a hysterectomy with bilateral salpingo-oophorectomy and pelvic lymphadenopathy. Hospital records are not available, but I was just told that they were told that we have removed the pelvic lymph nodes. So fortunately, her daughter remembered that, and that the uterus and ovaries were removed. So I have written this. And again, left eye cataract surgery was done. No hospital records available. Next, please. On examination, she is conscious oriented. All her activities of daily living are done by herself, unassisted. Her bathing, eating, grooming, she does by herself. Vitals were within normal limit. Class 1 obesity, BMI of 32 and waist hip ratio 1.2. Systemic examination was normal. CNS wise, there's no neurological deficit, there's no tenderness over the spine. The spine range of movements are restricted. Bilateral straight leg raising is around 30 degrees. Gait is she walks with a walker. Left shoulder range of movement again is reduced, just approximately 30 to 40 degrees. So if she has to try to comb her hair, she uses the support of the small marble which is there near the window. Next, please. Her investigations, blood tests were done last year. They were normal. An MRI lumbosacral spine was of 2018. Again, since she is not going down, going out of the house. L3, L4 levels severe central spinal canal stenosis, which is compressing the thecal sac and intrathecal nerve roots. Significant compromise of the bilateral recesses, left more than right, causing a compression of the bilateral inferiorly traversing left nerve roots. Grade 1 degenerative anterolisthesis seen at L3, L4 level, and there's a mild disc bulge seen right from L1 to L5 levels. For her burning sensation, I tried a trial of pregabalin 75 mg from neuropathic pain point of view, but it caused her immense drowsiness, so it was stopped. Next, please. Psychosocial aspects are she's a widow. She's living with her daughter who's unmarried, who's the basic primary caregiver. She was working earlier, currently unemployed since around 4 years. There are two sons who are staying separately and they're not very much involved in the care. The eldest son just contributes by managing the household expenses and just gives the money. Her medical expenses are managed by the daughter from her savings from previous employment. A patient has no income or any major savings and is financially completely dependent on the eldest son. She is depressed on account of her health issues, feels that she is a burden on her daughter who takes care of her because the daughter's entire day routine revolves only around the mother, as well as she has to manage the outside activities of the house. She feels completely worthless and there is no other family support system, no extended family. She's very devout and spiritual. Morning routine is her daily prayers, which go for about 2 hours, her reading and her chanting. She often prays for her death and often tells her daughter also to pray for her death because of the severe pain that she is when she gets up and the incontinence. She expresses no desire to live and often complains that God is not answering her prayers, and this seems to be a karmic punishment. She's also worried that what will happen to her daughter after her demise because the sons don't have any particular connect with the daughter as siblings. Next, please. Her current medications are for her thyroid, for her dyslipidemia, for her asthma, and Montair for her uh, asthma again. I had advised her to take tablet paracetamol 650 milligram thrice a day, but she's not taking it since she's not very keen on taking anything stronger. So this was what I could think of. Next, please. Her main concerns are that she has been refusing surgery since the past 20 years because she is fearful that a spine surgery will cause complications and then she will be completely bedridden. She refuses pain medication, stating that anyways they are not going to treat the root cause, they are temporary, they have more of side effects, and I'm already taking so many medicines. Diapers were advised to her so that her anxiety early morning and as well as in the afternoon. I told her at least at bedtime you can try to take a diaper, but she refuses them. One is the expense factor, and the other is it makes her feel like an invalid. She feels that what is the point of such kind of a life where you're on diapers? She refuses pain medications. I came across one orthopedics prescription where buprenorphine pain patch was prescribed, but again on account of its expensiveness, it was refused. Home physiotherapy here in Mumbai is quite expensive and ranging anything from 1500 to 2500 per home visit, and she cannot afford them. So, if they have to take her anywhere, that is again call the ambulance and take her on a stretchable stretcher and take her down the 20 stairs. So, that again is been out of question. Uh, this slide is basically the patient's main concern, but there are my main concerns which I've included is that only paracetamol will obviously not alleviate the pain, and opioids can cause drowsiness. She's using a walker and she may sustain a fall or a fracture. So maybe a clinician's hesitancy, you could say. Summary is an 85-year-old female patient with lumbar canal stenosis causing severe pain over the low back and both lower limbs with progressive restricted mobility and disturbed sleep, along with burning sensation over the back, both the lower limbs and genital area. There's element of anxiety, depression, and urinary incontinence. Yes, please. What is the discussion points I have like to discuss is what should be the strategy for pain management given her reluctance for medications and the adverse effects of drowsiness. The incontinence, is it a spinal canal stenosis or is it a urological, like it's a retention with overflow? Uh, should she be hospitalized for a complete assessment with a multidisciplinary team consisting of all the spine surgeon and neurologist, complete her cataract surgery in the right eye, an ENT opinion, physiotherapist, pain management specialist, a psychiatrist, and counseling? How to involve her sons and family in her care to prevent caregiver burnout in the daughter? How to encourage her to seek undergo the tests, like a new MRI is definitely there to be done, and at least seek a specialist opinion for her pain and to improve her quality of life, because there could be non-surgical interventions also for pain management, as I've tried to explain to her that it need not only be surgery. How to rekindle hope and willingness and the desire to live given her financial constraints, apathy of family members, that's her sons, chronic painful illness which has traumatized her physical as well as mental health. Right to good quality of life versus the right of autonomy. What should be prioritized? Because right now she refuses for everything, so her autonomy is being respected, but she has a right to good quality of life. So what would be the priority? Thank you.
Thank you, Dr. Dimple. I think there are a few comments in the chat about the pregabalin, whether this drowsy effect of pregabalin wear off after a while. And there are a few other suggestions on amitriptyline because it is cheaper and it can help a little bit in depression as well as in neuropathic pain. Then whether it is due to the senile vaginitis, these are some of the chats coming up. Dr. Punita is telling she has to be counseled for surgery or at least for diapers, homemade diapers or NGO support for such things. And social officer and psychologist counseling is important for her and her doctor. Any luck with NSAIDs and tramadol? That's what Dr. Nikhil is asking. Have you tried anything like that, Dr. Dimple? Any NSAIDs or tramadol, or she's totally unwilling?
Yes, no, I have not tried Ultraset, that is tramadol and paracetamol, again because she feels like I said, it could be a clinician's bias or hesitancy, because I'm more worried about her sustaining a fall. One is her obesity, one is her weakness, and so that all, I don't know how even to one dose of tramadol she might react. So that was my, and I did think of the TCAs like amitriptyline again, but then right now it's I've been trying to just break through her mental barriers to medications and to the diapers, and willing to probably get hospitalized for a complete assessment. And I feel that there has to be a multidisciplinary team which has to come in forth, so that the daughter gets a better idea and she can convey to the sons that what is to be done. And I'm also trying to locate, I've been told of an NGO who may be able to provide home physiotherapy support at pretty minimal subsidized rate. So at least the left adhesive capsulitis and maybe even something for the back we can start, so that and like ma'am had said about morphine, so I would really like some input on that.
So morphine is one, it's very cheap actually. Like, morphine is actually very cheap. So that is one option. Can I just ask, where does she stay? You said Mumbai, right?
Yes.
Where in Mumbai?
In the suburb of Khar. harvest.
And does she fall under any schemes, government schemes or anything?
No, ma'am. No, ma'am.
Okay. So what you can do is, just refer her to a government hospital, because the surgeries and the physiotherapy and every investigation would be a bit cheaper than outside. So maybe that is one option. And if you could just help her, because most of the the problems that she had relates back to the fact that she is financially dependent on either the son or the daughter, and she's exhausting her daughter, and that's why she feels guilty, and that's why she wishes to die. And it's kind of just circling around the fact that she's financially dependent. So if you could just maybe just arrange for funds to get all these things possible, then she might be ready to just go for the at least the investigations, if not the treatment. So that is one thing that you could possibly do. Second thing is start her on a very low dose of opioid. The sedative effect of the opioid lasts generally for just 2 or maybe 3 days, so it will wear off post that. So it can be tried, and morphine being a very cheap drug, like 10 tablets for I think 11 rupees or something like that. So, you can just get those arranged for her. Start off with a low dose of maybe 2.5 to 5 mg TDS or QID, according to what you feel might help her. Neuropathic pain, you can try, I'm not sure if you still get it, but you get lignocaine patches. So and those, you can just cut them up. They come in quite a large, like 10 by 12 centimeters of patches, I think you get, but you're allowed to cut it, unlike fentanyl patches and everything. So you can just cut it into like a smaller patch and just apply it over the back where she feels the maximum pain. So it will block the nerve roots itself. So, the whole thing will just go off without any systemic side effects. So, and it is something like, you have to put it on for 12 hours and just remove it for 12 hours. So it's just 12 hours of the day that you have to. They are a bit expensive, I agree. I mean, I will state that fact right out. They are a bit expensive, but you can, like, it's not that the whole patch needs to be put at one stretch. You can actually just cut it and use it as much as you want it and wherever you feel it. So that is another thing that you can possibly, if you can arrange it for her, or if you can just get in contact with the pharma companies who are making it, and if they are, just willing to give you like a couple of samples or something just to help her out. That is another thing. Second thing is, third thing is, I just, maybe catheterization, if she's agreeing to that, then, it might just reduce the burning sensation if it is because of the cystitis that is occurring. And have you ever had her urine checked? Because it seemed to increase just a couple of years. Has it been something?
The tests done last year were normal, and there are no urinary complaints of dysuria or anything else. And in fact, actually, I have. That's why I was thinking of the hospitalization, so that A to Z
Yeah.
everything is done, because she's also developing the fear of not drinking more water, because if I drink more water, then I will get urinary incontinence.
And as you said, it just increases when she gets up, like from supine
Yes,
to when she walks.
yes, it's usually she's sitting. She can hold it till she walks up to the washroom
Yeah.
in the daytime. But
So
the minute she goes for an afternoon nap and she sleeps at night and then she tries to get up, both the things are at the peak, the pain and the incontinence. It's
So
just not
might be,
yeah.
so it might be related to the pain, because sometimes even severe pain makes you feel like you want to, just want to rush to the washroom. So we need to make sure if it's like pain related incontinence that she's getting, or is it purely like a neurological urinary symptom that we are having. So you need to kind of get that thing also, figured out, like what exactly is the cause of that incontinence.
Yes,
So it
that's
is
what I thought. Maybe is it a urinary retention with overflow? She
Mm,
doesn't have the sensation that she's got this
but
ready
it will
to.
persist throughout the day. Now it will go on throughout the day. It will not be just
Yes,
when she's
yeah,
just getting up from the supine position.
yeah.
Um,
But can I give amitriptyline 5 mg HS with morphine 2.5 TDS?
she's asthmatic as well, so I would be.
Yes. Because
So,
for burning, the burning pain also causes tremendous anxiety and
Why not?
maybe not
Maybe start
together,
around.
ma'am, because both of them can cause drowsiness, right?
more
So I
drowsiness.
wouldn't
Right?
start both together. As Dr. Rutula was mentioning, low dose morphine can be like the drowsiness weans off in the initial 2 to 3 days. So maybe to prevent fall, we can advise them that while you're getting up, just make sure that you just
Yeah.
wait for some time or call someone. Just 2 to 3 days, be cautious about it. And then once when she gets used to the medication in 2 to 3 days, the drowsiness, I think the morphine will be something to start with. Then probably can think of medicines for neuropathic pain because
Yeah.
otherwise both of them can cause drowsiness. So
Yeah, and maybe start off with maybe like duloxetine or something like that instead of going for pregab or TCAs. They're less sedating than the rest. So maybe you can like jump off to the third line instead of going for the first, second line. That is another possibility.
Shouldn't we treat the depression?
So all the neuropathic agents are antidepressant in one way or the other. So but the antidepressive effects are generally take around 3 weeks to start.
Yeah, 2 to 3 weeks. I usually start off with the mirtazapine. It gives a wonderful effect without much of side effects. But take about some time. But it shows its effect after some time.
Yeah, sure, you can.
Could you just tell me the name again?
Mirtazapine.
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 Yes.
I start with
Yes.
7.5 milligrams HS and then can titrate up to even 15.
Yeah,
But it gives
it
a
actually
fantastic
increases
effect.
the appetite as well. So yeah, it's a good drug.
maybe once you start treating the depression, she'll be more open to take medication probably because with depression people
Exactly, madam.
don't
Exactly.
want to take anything. They just feel like everything is lost and they don't want to take any treatment.
Exactly.
So that is one thing. And having a family meeting is very, very important because they also might be exhausted. We can't blame them that they are not having any empathy. They'll be just totally drained of seeing this pain and suffering probably. So it's good to have a family meeting just to listen, even though you are not giving any advice. Let them to vent their issues. Just listen to them, whatever they have to tell you, and then probably having the conversation about patient, like how to go ahead with the treatment.
Yeah.
Cheaper measures will be acceptable to them probably. If you advise them higher medication or hospitalization in the beginning, they may not be able to accept it. So maybe just to start treating the depression, mild dose of morphine for pain. Once the pain is taken care of, probably many of these things will be addressed in a better way. And when we talk about the quality of life and the autonomy, like if she is depressed in this stage, she doesn't understand what exactly means quality of life for her, right? So whatever autonomy she's talking about, we don't know. We don't know what she's looking for. We can't say that it is as autonomy.
Okay.
Family counseling, treating the depression, and I'm sure low dose morphine will make wonders.
It'll be wonderful in her case. Yeah. And I'm not sure. I think cheaper lignocaine patches are also available. Like Modi Mundi ka one, like 2 patches for around 1,000 something. 2 patches, the big patches. So, but I don't know.
When you advise to cut that patch, how much? What would be the size you would say?
I would like, since it's a backache which is radiating downwards, like it's quite an extensive area, I would at least cut it into half of it or 3/4 of it and apply it over that. So it needs to be applied over the dermatome which is affected, right? So you'll need to apply it in the area of L3, L4. So so that it kind of covers the whole thing. So it's a good thing, like it works wonders even for, so we've seen it in patients with peripheral neuropathy as well, like just cut in small patches, like maybe 1/4 of it, and that was applied over the sole of the patient, and he could literally stand on his own afterwards. Like it was a very severe neuropathy where he couldn't even like put his feet down, But the next day he was standing up on his own and he was really happy about that. So it actually works very wonderfully, but I'm not sure about the availability. A certain
Madam, it is good for herpes zoster pain also.
yes, it is. It works wonderfully. It works wonderfully. The only problem is it's very expensive. I'm not sure if the rest of the like companies also are equally expensive. You can even try, like if she gets hospitalized, you can even try like a very small dose of ketamine, very small dose of ketamine, just to get over that acute pain that she's having. So like a very small dose, like maybe 2.5 mg or 5 mg, depending on how much she
Sublingual?
requires.
Sublingual?
Injectable, dilute 2.5 mg of ketamine, dilute it in like 10 ml of NS, like make a solution of 10 ml in total, and then give it like a very slow push, like a slow bolus. It works wonders. Like we had done this like group of patients where we gave ketamine for neuropathic pain crisis. All of them responded amazingly well. So like in 2 to 3 minutes, the pain was gone. So it works wonderfully. The effect does not last for long because it kind of just wears off in like half an hour to 45 minutes. But you at least know that it is absolutely completely neuropathic pain. So you give the medications according to that. So it works wonders.
And ma'am, if you're worried about the drowsiness part or response part of morphine, if you have in your setting, if you have the facility to do an IV titration, probably I would just start with that. So I'm sure that the dose which I'm giving, the patient is responding, and this is what exactly the dose is going to be. That's what makes us feel safer, so that you can give the tablet to home, just if you have access to that. There are a few questions before we wind up about the maximum dose of mirtazapine.
I think you start off with 7.5.
7.5, yeah.
And then to about 25. I've given it maximum up to 25. I've not gone above that, but I'm sure you can go above that as well. I'll have to find that out. I'll find that out and I'll let you know. I'm not sure about the maximum.
Mirtazapine can cause sedation. Is that Dr. Sujarita is commenting? Yeah, compared to escitalopram, yes, escitalopram will be a little safer if you don't want a drowsiness, but it will take longer time to start acting. But mirtazapine, yes, it causes some sort of sedation in patients.
So any of the SNRIs or SSRIs or whichever, like even TCS for that matter, the complete effect is seen only after 5 to 7 days. So if you want to up the dose of all these medications, you need to wait at least 1 week before you up titrate the medications. So be very careful. Like don't just abhi aaj nahi hua to kal badha diya. Don't do that. Just wait for at least a week before you increase or from HS to BD or whatever, however you're titrating it up. So
but would it be okay to give it along with the morphine?
Yeah, it should be fair enough.
Again,
don't start everything together.
Yeah, that's what.
Then we
Okay.
don't start any medication, like all of these medications. I won't start together. I'll start with the best available and the simplest one, and then go to the next, because then we don't know which medication helped. So it's better not to start everything together, but one by one. Dr. Swati has mentioned about the mirtazapine, the up to 45 milligram per day can be given for depression. Thank you, Dr. Swati. About how slow you can give ketamine is another question.
Over 3 to 4 minutes, like slow push. Not even an infusion. It's like a slow bolus push of 10 cc. So maybe 3 minutes or 4 minutes. It's fine. Frequency of so usually the effect lasts for around 30 minutes, and after that they'll like, okay, the pain is starting again. So you can give the bolus again, but it will just wear off within half an hour. So you cannot keep the patient in your OPD for longer times, right? So you might need to kind of tell them ki ye ho gaya hai, ye uske liye dawa diya hai. So this is the medicine you're starting for that particular type of pain, and it should have its effect in a day or two. So you can just give that. So another way to do is you can give magnesium infusion as well. So magnesium also acts on the NMDA receptor. So that should also help. So 2 grams of magnesium sulfate in 100 ml NS, like a infusion, like a slow infusion, not a slow infusion, but like over 10 to 20 minutes. So that sometimes helps along with your ketamine to manage a neuropathic pain. And another NMDA receptor is Benadryl. You can actually give Benadryl DR, like dextromethorphan. So dextromethorphan also acts on your NMDA receptors, but it is very sedating. So like you'll just sleep throughout the day. So yeah.
So I can think of duloxetine probably after the morphine trial, and she's got adjusted to morphine. So maybe 10 mg of duloxetine that it could help with the neuropathic as well as the anxiety part and the depression part. You said it's less sedating.
It is.
My main focus is to try to get her all her tests, get her completely evaluated and get a spine surgeon's opinion, whether we can go in for some other pain management for the spine, because there is something required long term for the spine. Once she is mobile, she'll be out of the depression, because what basically kills her is that she's not able to walk at all. And also I had read that about solifenacin to be given, but then again an ultrasound it will be required for that. And I had seen another question, there are no bed sores.
Okay. So I think you should just shift her to maybe a government hospitals. They have good orthopedic departments, most of the hospitals in Mumbai. So maybe just get her to a government setup. Almost all the tests and everything are very cheap, comparatively very cheap there. So you could get those done and maybe arrange for some sort of financial support if required. Hopefully she'll take that.
Thank you. Rutula, one more question. I have answered from my side, but what is the most common caregiver challenges that you see in non-cancer illness? My side, I answered it is burden of caregiving for a prolonged period of time and the unpredictable nature of illness, unlike in cancer. You can't say how long it's going to be there.
And you know what happens with cancer is that the diagnosis itself is like, oh, he's going to die. Like, the diagnosis of cancer itself, even if it's at a curative stage, there's like cancer hai to manje, he's going to die. Like, that is like a doomsday for them. Non-oncology is like ye to theek ho jayega. And when you start off the treatment, they actually become asymptomatic. Like when they start responding to the medications and everything, they actually are very asymptomatic, where it's like ha theek ho gaye na, and the doctor always say ki ye dawai lo, patient theek ho jayega. So they always spell it out ki it's equivalent to cure. They never kind of explain, like we never explain the patients that this is a chronic illness and eventually it will stop responding to the medications and deteriorate further, and what is the trajectory. That's never explained by us as physicians also. So I think that is challenging. As you said, the caregiver burden is always there because of the trajectory and because of the in and out of the hospitals and everything. But the whole concept that this is a terminal illness or it's a lifelong chronic illness which kind of deteriorates over time, that concept is never inside their head. So they always feel ki ye to theek hone wala hai, he's going to get better. She is going to come out as normal and start doing whatever she used to do previously. So that is the concept that they have in their mind. And yeah, more or less it's mostly to do with I want everything done for my patient, like everything done for my patient. So even if it is like harming them more than benefiting them, I want everything to be done for my patient just because I can, like just because I can, like they can afford it, they can afford it. They'll manage like 2 months of ICU stay also, just because they can. On the other hand, the patients who actually would benefit from whatever sort of treatment that can be given, they have financial crunches, like they have a lot of financial crunches. So that is what I see in my practice, like people who would have benefited from like 2 days of extra stay in the ICU cannot afford it and get terminally discharged, and eventually I go at home and just kind of succumb to the disease, versus patients who are who you would deem to be medically futile but can afford the stay in the ICU and are continued on care. So that there's a lot of discrepancy on what goes on in the management of the patients. Like sometimes the doctors and the caregivers just give up because of their financial constraints. Sometimes they continue despite everything because they don't have any financial constraints, and they have so many schemes. And so sometimes in my hospital, one patient has all the possible government schemes that can be given. So he has let municipal wala this thing also, the prime minister funds also is going to him and everything. I'm like, for one patient, you cannot give so many schemes to just one patient. There are other people who require it. So there's a kind of a lot of discrepancy that goes on while treating you. So in oncology, that is not even not only in non-oncology, even in non-oncology, finances play a big role in how the patient gets managed. The attitude of the caregivers and the patient herself or himself affect the the decisions that are taken for their care. As in, as we saw, she did not want to get treated. So it leads to worsening of their symptoms and worsening of the quality of life, and the caregiver burden at the end of the over the years, it kind of just builds up. And especially if the caregivers don't have a support themselves, so it kind of builds up and it just spills over after a couple of years and or decades.
Thank you so much, Rutula, and thank you so much all the participants for your interaction and your contribution towards the case presentation. It will be wonderful to know from Dr. Dimple after a few days, like what did you try and how did it work, so that we can all learn from each other. It will be nice to hear about if we can share after you try. And please feel free to use our telehealth line if you find any difficulty in starting and titrating the medication. The number I can share in the WhatsApp group. We have a telehealth facility available where there will be a doctor and the nurse available. So you can
Thank
take
you so much.
suggestions from them.
Thank you so much.
Thank you so much, everyone. Sorry for overshooting time, but this was a wonderful discussion, so I didn't want to stop in between. Thank you so much, everyone, and over to you, Shri.
Thank you, Dr. Rutula, for joining us maybe towards the end of the day and giving such brilliant presentation. I hope that everyone had at least one point new to learn from your lucid presentation. And thank you, Dr. Dimple, for this wonderful case scenario as well. And thank you everyone for joining and making this session as interactive as possible, like all of the previous sessions. So with the promise that we'll be again meeting after today's with another interesting topic and yet another eminent faculty. This is Sri Priya along with Dr. Rutula and Dr. Sridevi signing off from the Tips Eco Hub. Till the time we meet again, stay safe, be happy. Bye-bye.
Bye-bye. Thank you.
Thank you everybody for your good comments and encouraging. Thank you so much.